Uh, Very good evening to all of you. This is our seventh episode of NextGen mock examination, and we have with us two very eminent and renowned pediatric surgeons of the country and the world, Dr. Ramesh Sanathakrishnan and Dr. Prema Menon. Today's case is on Hirschsprung's disease, and it is going to be presented by Dr. Chaitanya from Indira Gandhi Institute of Child Health, Bengaluru. Along with this, as usual, we have a top-up quiz which will be conducted by Dr. Manish Pathak from AIMS Jodhpur. So I hand over the mic to Chetan. Chetan, please go ahead with your presentation and start your case.
Good evening, everyone. I'm Dr. Chaitanya, second-year resident pediatric surgeon at Indira Gandhi Institute of Child Health. Today, I'm going to present a case of 1-year male child by name. So are the slides playing, sir?
Yes, sir, it's displaying. Chaitanya, go ahead.
Today, I'm going to present a case of a 1-year-old male child by name Ayush, who is a native of Assam, with an informant of mother, who is a reliable source. 1-year male child presented to us with an intestinal stoma fashion during 3 months of age for complaints of abdominal distension, loose stools, fever, and refusal of feeds, not settling down with the rectal washes. Now came for a definitive procedure. On further questioning, child was a single-term male child with a normal vaginal delivery, birth weight of 2.8 kgs, cried immediately after birth with no history of NICU admission. Child was fed on day 1 of life, exclusively breastfed, had an admission on day 5 of life for complaints of abdominal distension and jaundice, and not passing meconium since 5 days. Child has been admitted in the ICU. Mother was informed that distension has been reduced on initiation of the washes and needed further evaluation. On day 8 of life, child underwent some dye study, followed by which a surgical procedure was done, most probably a rectal biopsy. Based on this report, the child was continued on rectal washes and was sent home. The mother was compliant with the administration of the washes. Child was decompressing well on washes till 3 months of age. Later, at 3 months of age, child had complaints of abdominal distension, foul-smelling loose stools, vomiting, and refusal of feeds for 1 day, for which child was brought to RNC. Upon receiving the child was managed conservatively with antibiotics, rectal decompression, and rectal washes. Further management, child underwent multiple eye study with X-rays and blood investigation that showed, based on these dye studies, child had underwent a laparoscopic procedure. Mother was said that child had underwent multiple biopsies with a stoma. Post this laparoscopic procedure, child on POD3, child had symptoms of peritonitis, for which child has been further taken for a redo laparotomy, and multiple biopsies were done and stoma was fission. Coming to the rest of the history, child had no other history of fever, loose stools, or distension currently, no history of hearing loss or skin pigmentation, no history of passing hard stools. In the antenatal history, mother was a 20-year-old female with a non-consanguineous marriage. Her antenatally case, 3 scans which she underwent at the pregnancy showed all the normal reports. Not a known case of gestational diabetes, hypothyroidism, or hypertension, or no history of exanthematous fever. She had taken all supplementation prescribed during her pregnancy. Natal history. Child is a term child born by a naturalist with a birth weight of 2.8 kgs, cried immediately after birth, and didn't require any NICU admission. Family history, which is not had nil significance. Child was immunized up to date, and development was appropriate for his age. Coming to summarizing my history, the term male child admitted with abdominal distension and not passing meconium at neonatal period, managed conservatively with rectal washes, and had underwent rectal biopsy at the neonatal period. Later, at 3 months of age, had complaints of abdominal distension and loose stools. On further investigating, he was found to have dilated bowel loops in the X-rays, for which antibiotics and rectal washes were tried initially. Later underwent laparoscopic procedure with and in multiple biopsies. Later, with the suspicion of perforation on POD3, he underwent a laparotomy and multiple biopsies, and stoma was fetched. Can I proceed further, sir?
No, I think we can just ask you a few questions.
Stop there. Yes, Prima.
Yeah,
Please.
just, so can you tell me the birth order of this child?
Ma'am, you're not audible, ma'am.
Birth order.
Birth order.
Yeah.
He's asking about birth order of the child.
How many siblings?
Maybe a third one.
Can you hear me?
Can you hear me?
Yes, sir, I can hear you.
What Dr. Prema Menon is asking is, do you know the birth history, birth order? That is,
Yes,
is
sir,
it the
he was
first
the
child or second born child or
first-born
third?
male child.
Okay.
Okay.
So you said family.
I have a few questions. Yeah, tell me. Go ahead, Prema. Please, Dr. Prema, go ahead.
Okay. What exactly? Are you not able to hear me at all?
Ma'am, your voice was breaking, ma'am.
Actually, it's
Maybe Prema, you can use your headphones or something, because we are also not able to hear.
Okay.
Okay, when she was getting back, I'll come back to this, because there are two questions which are being asked about from Dr. Ramesh Krishna about gestational diabetes mellitus. You asked for a history of gestational diabetes mellitus. Is it of any significance, Chaitanya?
Mother with a gestational diabetes can have children with delayed passage of meconium, sir.
What is it called? What is the condition called?
Lazy left colon.
No, small left colon syndrome. Okay, or also called as lazy left. And then somebody's also asked about the significance of birth order, but I think Dr. Prema Menon has to answer that, because even we are not too sure. If Prema comes about, somebody please, everybody else mute their phones, please. Okay, Saravanan, Salem. Okay, am I audible now?
Yeah, you're audible. Please.
Okay, you said that child perhaps underwent a rectal biopsy. Perhaps they thought it could be Hirschsprung's. I agree. But they suggested that the child can undergo washes, for which the child was all right with washes for 3 months. Now,
Yes.
my question to you is, which are the children with suspected Hirschsprungs, where you will say, I will manage it washes and wait for some time, or which are the children will say, I will do colostomy, or which are the children where you will do primary procedure? Am I clear?
Yes, sir. Children with a short segment Hirschsprung's disease, who are initially decompressing with washes, can be managed with washes for the further periods.
Okay. What about the other two? When will you say colostomy is needed? And when will you say it's okay, I will do it primarily right now, I will not wait later?
Child having multiple episodes of Hirschsprung's associated enterocolitis, not settling down with rectal washes, we go for a stomas.
Not necessarily about rectal, because in a newborn period, we don't expect the child to have enterocolitis. Okay. So we expect basically the child is presented with abdominal distension. And if the child does not decompress with bowel washes, then you have two choices. One, either you can do a primary pull through, or you can do a colostomy and a deferred pull through. The difference between the two is about how well is your setup, how comfortable you are to do a neonatal primary pull through, and the child's status. If the child is comfortable, stable, and you think you can go ahead with it with a primary pull through in your setup, yes, you can even do it at newborn period or even 1 month. But if you think you're not comfortable, the safer option is to do colostomy. Prema, have you come back? Prema?
Does it make it any better?
Much better, but still not fully clear, Prema. We'll be very happy if you can ask. I'm just holding fort for you.
With the laptop, I think. So it's an own laptop. So okay, no, I didn't mean birth order that way, but basically wanted to know about the siblings of the child.
Okay.
Just to know about siblings.
Siblings also, okay. Now she makes sense. Chaitanya, she says, does it make a sense to, I mean, does it, is there any significance of the siblings' history?
Yes, sir. If at all a female child who was a firstborn is having a long segment Hirschsprung, her sibling being a male has a chance of 30% to have this Hirschsprung disease.
Okay, yeah. So
Okay.
previous family history, especially long segment background.
Prema, your audio is still not okay. I don't know what is happening. Do one thing, Prema, what you can do is you can just type your questions. We'll ask on your behalf. Vikesh?
Absolutely right, sir. Absolutely right, sir.
Let her type her questions and Vikesh, you can follow up with her. Till this time, I'll be holding the fort. Okay? We'll be happy with Prema's question. She's a senior surgeon. We'll be very happy. Now, you said the child underwent a rectal biopsy. Now, I'm asking about what sort of rectal biopsy you thought has been done on the baby. Chaitanya?
So what sort of a rectal biopsy?
Do you know the types of rectal biopsy which can be done?
Yes.
Do you know the different types of rectal biopsy and what sort of biopsy you think has been done on this baby?
So partial thickness biopsy, suction biopsy, and the full thickness biopsy.
What sort of biopsy do you think has been done on this child?
This child underwent a partial thickness biopsy.
What do you say it is a partial thickness biopsy? I say it is a full thickness rectal biopsy. Can you please prove me or disprove me? The answer I was expecting was whenever you do a full thickness rectal biopsy, it will be difficult to do rectal washes post-operatively. Okay, there's a chance of rectal perforation. So generally, a child where the decompression is going to be dependent on rectal washes, we do not suggest for a full thickness rectal biopsy. Okay. And if you're doing a partial thickness biopsy, yes, you may. Mucosal suction biopsy, yes, possible. And what is the difference between a mucosal biopsy and a partial thickness biopsy that you're talking about?
Mucosal suction
Chaitanya, am I audible?
Yes, sir, you're
Yes,
audible.
go ahead.
Mucosal suction biopsy, sir.
Yes. You said there are two other types of biopsies. One is a partial thickness biopsy and mucosal suction biopsy. I mean, what is the difference between the two?
Suction biopsy doesn't require any anesthesia for it to be done, sir.
Okay.
It can be done
If that is the case, why didn't we do it for all children?
Sir?
In that case, why don't we do a suction biopsy for all children? No anesthesia.
It
You
might
can do
not
it as a
yield
simple
adequate.
procedure in the bedside or an outpatient.
What layers you include in these type of biopsies that will give you the answer?
Submucosal layer
Because
should
please be in touch with if you say mucosal suction biopsy, you will not get submucosa, right?
Yes.
So what is the prerequisite for doing a mucosal suction biopsy?
Pressure, sir.
You should have one. No. You should have an excellent pathology department who can back up, an experienced pathologist who can also look for what are the pathology findings that you're looking for in a biopsy.
Absent ganglion cells and hypertrophied nerve fibers.
Okay. See, when you say absent nerve bundles, I mean absent ganglion cells and hypertrophied nerve bundles, which layer do you see it best? Which layer of the rectum do you see it best? There is mucosa, submucosa, muscularis, and serosa. In the upper rectum, serosa, and lower rectum, no serosa. Now tell me, what you said was about absent ganglion cells and hypertrophied nerve bundles are seen best in which layer?
Muscularis mucosa.
Understand? So when you're doing mucosal biopsy, you may not be able to comment on these two. So what else will you look for? Do you have any other biopsy methods, techniques to do it apart from the routine hematology you said?
Some other advanced staining you would like.
Acetylcholinesterase staining.
Okay. What does it tell you in acetylcholinesterase? What do you exactly see? In acetylcholinesterase, you see actually a positive diagnosis. It's not absence of ganglion cells. Hypertrophic nerve bundles will be seen as a staining of that. Okay. Other option for advanced immunohistochemistry is, any other technique by which you can do apart from acetylcholinesterase? Yes?
Calretinine. Calretinine, sir.
Calretinine. Okay, calretinine. Now, if you want to take a biopsy and send it for this partial thickness, and you want to do routine histopathology and acetylcholinesterase, how do you send the biopsy?
You are now connected.
How do you send the biopsy? Technique of sending the biopsy as a surgeon?
In a saline, sir.
Saline. If you are going to send it in a formalin, how will you make sure that it is taken?
The sample should be spread over the gauze piece and sent in the formalin.
And hard and Prema Menon ready to talk if there's any issues.
Yes,
Any
yes.
question from our
Can
side?
can
Please
you
go
hear
ahead.
me now? Can you hear better?
Yes, ma'am. Yes, ma'am.
Yeah.
Huh. So, like,
Yes.
yeah, Dr. Ramesh was asking you about acetylcholinesterase, and we said that's a positive kind of staining, isn't it? So, when we talk about calretinine, what exactly are we saying here?
Absence, ma'am.
Okay, so what kind of histopathology examination is that? I mean, what exactly is it called? Like, what is it part of?
Enzyme histochemistry.
Okay, immunohistochemistry kind of thing. Okay, fine. No, so there's an absence of ganglion cell and you have a loss of calretinine, isn't it? Yeah, so that's correct. So the other thing is, I just wanted to know a little more about the submucosal biopsy. Where do you take it?
1 centimeter above the dentate line.
So why is that?
Below just up to 1 centimeter above the dentate line, it is a physiological aganglionosis.
Okay, fine.
Yeah.
And same with the nerve fibers, same problem. So would you take one biopsy or you should take at least, it should take more than one?
We take only one biopsy.
No, ideally you should take at least two. That is what is recommended. So say at 2 centimeters, 3 centimeters, 4 centimeters. That is what is recommended. Also, is there any specific way in which you take whatever biopsy you take, is there any specific way in which you should be sending it? Apart from, of course, for submucosal biopsy, you said you'll keep it in a saline gauze. But let us say any rectal biopsy, how exactly should you be sending it to the pathologist? Will you just put it into a, into any container and send it, or is there any other way you should send it? I mean, what is the importance?
Frozen section.
No, whether it's submucosal, no, not like that. See, basically, you should always mount it if possible. And for example, submucosal should have mucosa and submucosa. There should be some at least 3 millimeter size. I mean, these are all recommended. And even when you take full thickness biopsy, you should mount it on something, on some flat, whatever, say a suture material cover or whatever, and then mount it and orient it basically. In the sense you attach in such a way that pathologist knows which no, don't just let it crumple and be sent. You should mount it properly.
In other words, Chaitanya, what madam is trying to say is, If you just drop the tissue inside, it will tend to curl. And when
Sure.
they section it, you may not have a representation from all the layers. So it is always necessary to flatten it, dry it on some surface, then put it in formalin. All right.
Yes.
So I just wanted, since
Now you talked about leveling biopsy. Somebody did a leveling. Prema, please.
no, please go ahead. Please.
Chaitanya, you talked about leveling biopsy.
Sir.
What exactly you do in a leveling biopsy? When you take a
Sir,
biopsy,
in leveling biopsy, we take multiple biopsies starting from the peritoneal reflection, next in the sigmoid, then on the descending colon until the transition zone.
just transition zone or beyond transition zone?
Beyond the
Also?
transition zone, 2 samples beyond the transition zones, 5 centimeters and 5 centimeters from the transition.
What sort of layers do you take here? We've been talking about mucosal, submucosal. What do you take here?
Seromuscular biopsies we take.
What do you do apart from? So I understand you take a seromuscular biopsy. When you're in the process of taking a seromuscular biopsy, what else do you ensure? How do you close it? Do you want to close it at all? If mucosa
We do not. We ensure that we do not perforate
need to close it, no?
mucosa and close it with a non-absorbable suturing so that it will be helpful in the future as a markings.
Okay. Now, in case you accidentally perforate, what do you do?
We close it
to make it a non-perforative biopsy. Yeah.
Yes.
Tell me. You close it, the perforation, and suture it and make sure that you're going to see it very well.
Yes, sir.
All right.
So,
Dr. Prema, anything that you want to say?
Yeah, no, everything is fine. Just one more question. So one is that, yeah, can you hear me?
Yes, ma'am.
Yeah. So one is, you have opened first time, so you're doing a leveling colostomy.
Yes,
is there
we
any
can.
other indication where you may take multiple biopsies?
In suspicion of total colonic agangliosis, we take multiple biopsies.
Okay. Fine. No, supposing what I'm
No,
trying to
Prema,
say.
I would like to say yeah, please go ahead. Please go ahead.
No, see, sometimes what happens is a patient may have been operated elsewhere and they just have a colostomy or an ileostomy and you really don't, and you're going in second time. So here you have no idea because there is no way you can do a contrast enema because that also is gone now. The option is gone because there's a stoma. So that is again one place where you may take multiple biopsies because you don't know the diagnosis. So not just total colonic, okay, you may take, but you will also take when a child has a biopsy just from the history, but there's only a stoma and you can't do anything else now. So you'll be taking multiple biopsies to, one to know the diagnosis and also to know what is the level of your aganglionosis, if at all.
Very true, Prema. In fact, in addition to that, I would like to say that there was a time when people used to do brain right transverse colostomy without any biopsies. In that case, also you require a biopsy. One. Number two, sometimes they have done a biopsy, but it has not been correctly interpreted. Three, the biopsies have been done, even if the slides are available, at least we can get a recheck by a good pathologist. Sometimes you don't get that also. And you're not too sure of the level. It is better to do multiple biopsies before going in. I think that's what Dr. Prema is trying to tell.
Yes.
Am I right, madam?
Yes. Yeah. Yeah.
Okay, in this case, for example,
you will waste
in this
lot
case,
of
if you look at it, yeah.
In
this case, when you say the child presented at 3 months with abdominal distension, not responding to anything, they've done a biopsy. Don't bother whether it's lap or open, it's the same. But they have not done a stoma.
Yes.
I think that could have happened because conventionally, when we take a biopsy, we also do a stoma. Why do you think they've done just a multiple biopsy and not a stoma?
So if at all the child is decompressing well with the washers, we are just doing the leveling to just map the abdomen.
But could it be anything else? Could it be anything else? See, if the child is decompressing, they are planning for an elective procedure, so they've done a multiple biopsy is another one. But is there anything else by which they've gone inside they taken a multiple biopsies but not a stoma, do you think is there any option? Why? Audible?
So, mother pathology.
Yeah, what I'm saying is, once they go inside for multiple biopsies, if the transition zone is classical, yes, you could have done a colostomy at that level. But when you go in where the transition zone is not very clear, either on barium or on the laparoscopy or laparotomy, you better still to do a multiple biopsy, come out, wait for about 24 to 48 hours, get the biopsy going inside, than to cite a biopsy, colostomy wrong. Now, last question before going further from my side is, what is the difference between leveling biopsy and leveling colostomy?
So leveling biopsies is that we do multiple biopsies until the transition zone, and we do the stoma at the transition zone. In case of leveling
Transition zone? One second. Transition zone or proximal?
proximal
Above
to
the transition.
In case of leveling colostomy, we do a Hartmann's and do the resection of the suspicion of this Hirschsprung segment and do a proximal colostomy.
No, basically in a leveling colostomy, you make sure that the colostomy is going to be just a proximal. You take out the entire segment of the transition zones and send for biopsy. Okay. And you do a divided loop colostomy. In a leveling biopsy, you take multiple biopsies, and a colostomy can be placed much proximal. Now, I think some Dr. Varsha is asking about, in case you send for biopsies, it says immature ganglion cells. What do you do next?
Sir, immature,
I know what to do. I'll send it to Prema.
immature ganglion cells at what site, sir?
No, that's what somebody has asked. Tell me. Okay. What I'm saying is, whenever there is a doubt about this immature ganglion cells, hypoganglionosis, etc., it's better to rely on creatinine or what do you call your acetylcholinesterase. Now, if they say and report as hypoganglionosis, can you get the slides reviewed for acetylcholinesterase? You only answered it earlier. Now, how do you send the sample for acetylcholinesterase? How do you send it for HND?
Fresh frozen sample. Saline sample.
If not a distributed, Mala again distension is there. It is fluctuating distension. Again, not child has not passed stools again. At 6 o'clock, child has passed 2 diaper.
Can you hear me?
In the morning, no stools.
I'll request all the participants who are not
back
speaking,
or
kindly mute themselves. I'm constantly muting
and
everyone.
Vikesh, can you mute everybody else except the 3 4 of
Yeah, I am constantly doing that. Still, they unmute themselves. Yeah.
Can
Yeah,
I
please.
just make one comment, not specifically, just what you said? We never make a stoma in the transition zone. Somewhere you said that we should not make. Yeah, it's always in the ganglionic bowel.
Perfect.
So, and the other thing is transition zone. Is it the same at every part of the bowel? I mean, there are different types of Hirschsprung, isn't it? Based on the length of the aganglionic segment. So, is there any literature about the length of the transition zone?
Usually 10 to 15 centimeters.
Where? Everywhere? So usually it is said like for short segment, which is like rectosigmoid, it's about 5 centimeter. So at least that much you should excise after you see a contracted segment. But as you go higher up, more proximally, that length of transition zone will be higher. So if you go to say small bowel, then you will probably have to excise at least 10 centimeter. I mean, that is minimum. So it will be more. That is what is said. So you said total colonic aganglionosis. What do you understand by that word?
Total colon along with the terminal ileum is aganglionum.
Roughly how much? What is there's no proper definition as such, but so about 5 centimeter of terminal ileum, that is considered as total colonic. And of course, it can be a little more than you may say small bowel aganglionosis. Okay. And just since I couldn't speak properly before that, antenatal diagnosis, what else, what exactly are you looking for? I mean, what are you asking? Like, why are you asking antenatal diagnosis? Is there any relevance? You mentioned, no? I mean, what have you asked? Of course, I suppose it's normal in this child, but
In other words, is there anything in the antenatal history which will be of significance?
Sir, meconium mileus can be
Chaitanya?
antenatal scans.
okay. So partly for a differential diagnosis, is that right?
Yes, ma'am.
Okay. So what are the other
Is it possible to
differential
diagnose or suspect? Yeah. Go ahead. Go ahead. Go ahead, madam.
Yeah, no, just differential diagnosis. I mean, what are you thinking about? In the
What I'm asking
differential-
is it possible to pick up or suspect Hirschsprung's disease and antenatal? Chaitanya, are you clear about what madam is asking?
Is it possible to diagnose
If
Hirschsprung's
frozen.
antenatal?
Yes. Is it possible for you to suspect?
Yes.
How?
Echogenic bowel in the ultrasound.
Okay, I think we have had enough for the history. I think we got only 15 minutes for our discussion. Can you please
Yes.
go to the examination and then we'll discuss about it and go forward.
Yeah, yeah. Go ahead with the slide.
Coming to the general examination, with due consent, child examined in well-lit room. Child is active, alert, pink, and playful.
No. Since we are running short of time, Chaitanya, is it possible? Chaitanya,
Sir,
since we are running short of time, can we just go ahead and tell only the salient points? General physical examination, normal.
examination
Is normal. Then go ahead.
Examination is normal. Coming to systemic examination, for abdomen is non-distant, umbilicus is in central, inverted. Respective quadrants move equally with respiration. Loop colostomy noted in the right upper abdomen. Adequate spur is seen with the stoma. Both the lumens are seen completely and separate. Mucosa was seen to be moist and pink. No parastomal herniation. Adequate lumen size. Functioning proximal stoma. No peristomal excoriation. External genitalia normal. Bilateral inguinal regions normal. Renal angles and spine are normal.
Anything else? No. Anything else which is very important, which you should tell in a child with Hirschsprung or suspected Hirschsprung? Maybe we rushed you to tell, but you have to tell about the anal opening.
Ma'am.
Have you told us that?
No, ma'am, I didn't tell in the inspection. In the palpation, in rectal examination.
No, that is different. You have to tell, you have to look at the anus in the first examination. Otherwise, you'll be treating Hirschsprung's and the child may be having something else. So
Right.
the anal opening location, if there's, it may be a
Good
lower
one.
one with some, bucket handle, you don't know. So you
Right.
have to tell that in the inspection. That's very important.
Ma'am.
Okay. Go ahead.
On palpation, abdomen is soft, non-tender, no local rise of temperature, liver and spleen non-palpable, no other palpable masses, stoma healthy, do not bleed on touch, no parastomal herniation, inguinal orifices are intact, spine is normal. On percussion, normal resonant note heard, liver dullness in fifth intercostal space, liver span of 7 centimeters, no free fluid. On auscultation, normal bowel sounds heard. Per rectal examination, no feculomas present. Normal rectal tone.
So
Other
just
exam,
wait. No, just wait. Rectal exam, what else should you see? This child is presented with constipation and somebody has taken biopsies. Delayed passage of meconium, agreed. But should you be looking at something else when you do a rectal exam?
look for the scar. Previous.
No, that's okay. That's okay. But you should look for any mass if you're palpating anything. So sometimes you may have a anorectal stenosis, and sometimes you may have some lesion behind the, it can be in front also, more commonly behind the rectum. So anything, it could be sacrococcygeal mass or rectal duplication, the curarinostriate, those sort of things. You should just keep it in your mind. So the anus examination and PR, these thoughts should be in your mind, not just thinking of Hirschsprung. Yeah.
Ma'am. Coming to other system examination, CVS and CNS are normal. Respiratory system is normal.
What is the importance of saying all this, and what are you ruling out by saying all this?
Ma'am, in Hirschsprung is associated with other cardiac anomalies and urinary tract anomalies.
What is most common? What kind of disease you could say Hirschsprung's is? What exactly is it called? Is there any term for that, for Hirschsprung?
Central cyanotic.
No.
No. What is she talking about? Madam is talking about Hirschsprung's disease. What can be a part of?
Yeah, and why?
Down syndrome.
Look for.
Okay. Down's is
Syndromic
okay.
association.
No, but why?
Apart
Why
from that.
does that occur? What kind of syndromes occur and why? There is some reason for that, isn't it?
Neurocystopathies.
Yeah, that's what I want you to say. So then you will look for other similar things, isn't it? So what are you looking at, which you haven't really told in your examination? Because we asked you to quickly go through it. Maybe that's why. So what else have you examined?
White hair lock.
Okay.
Hypopigmentation.
Okay.
Heterochromia of eyes.
Fine. Yeah. Skin, anything else?
Skin hypopigmentation.
Apart from that, any other spots?
Neurofibromatosis.
So what is neurofibromatosis associated with some sort of spots?
Capillate spots.
You can, yeah. Okay. So, and definitely you must look for deafness. We have had children who are mute and deaf, and parents also are. So sometimes part of it gets carried through the generation. So there should be that history. Deafness is important.
Ma'am.
Okay. And some mental retardation, that also we have seen. So that is also something which you should tell in your general examination. May have some urogenital problems, but not that common. Even cardiac, not that common. But neurocystopathy sort of thing, you should mental retardation and all this. Okay.
Yes. Coming to my clinical.
Why do you think right upper quadrant stoma is made? I mean, that's not, you said right upper quadrant stoma,
Yes,
isn't it?
right upper quadrant stoma was made.
Why do you think that was done?
Could be a long segment Hirschsprung's, ma'am, with a transition zone at the splenic junction.
Any other reason? Because here the child has been operated twice. There's a laparoscopy, then a laparotomy. And laparotomy is done because of peritonitis. So why do you think peritonitis occurred?
Missed perforation in the previous biopsies while it was taken.
So some perforation in a previous biopsy. So it actually alters what has happened, isn't it? Otherwise, you wouldn't really want to make a stoma in the transverse colon, probably. That's where it's made. Okay.
Yeah. Coming to the clinical impression, 1-year-old male child with colostomy done at 3 months of age, possibility of a Hirschsprung disease, and thriving well.
So what do you want to do now? You
now
have the reports? You have with you?
Yes, ma'am. I would like to see for all his previous investigation, go through his X-ray reports and biopsy reports.
So do you have X-ray from newborn period?
Yes, ma'am.
Before people did anything?
Yes, ma'am.
Okay.
Yes.
This was an X-ray on day 5 of life where the child presented initially with abdominal distension and not passing meconium.
Are you showing it? Because I'm not able to see. Is it being shown?
Yes, ma'am.
Okay, okay. Sorry. I've turned the. Okay, this is at day 5. Okay.
Yes, ma'am.
Please read it.
Plain X-ray AP view of chest and abdomen with dilated bowel loops seen both in central and
Chaitanya?
sir. Sir.
Good.
Please go
Running
ahead.
short of time, quickly.
Plain X-ray AP view of chest and abdomen with dilated bowel loops seen both in center and periphery. Rectal paucity of gas in the rectal pelvis.
Not really. I mean,
Okay, good. You didn't suggest anything.
okay.
Sorry,
So
tell me, Prema. Sorry.
no, I feel that in the periphery it is more dilated. That is
Correct.
probably colon. We are not supposed to say colon and small bowel, but definitely it looks like transverse colon and left colon are a bit dilated, and then you see something more narrow going towards the pelvis. This is what
Yes.
something like that. Yeah,
Agreed.
that's right.
Agreed. Perfectly all right. So does it say anything to you, Chaitanya, with whatever Madam has said? Interpretation plain X-ray, is it suggesting anything to you?
Could be a short segment Hirschsprung with
You don't know.
considering that there is a
You can't say short segment. Okay, what else would you do next? Dr. Prema, I'm going to hasten it because we don't have much time.
Yeah, I know
So
this.
we'll put the start.
Yes.
Sir, I would like to do a dye study.
Chaitanya, go ahead.
I would like to do a dye study based on this X-ray findings.
Do you have the dye study at that time?
No, sir, we don't have the dye study we don't have the dye study at the initial.
So you, in all purpose, okay. At this stage, what do you think? For example, this say, so at this stage, they advised rectal washers and sent. Obviously, the child must have been decompressing and the child has been sent home. We'll agree. So it must have been perhaps short segment, we don't know. The child was all right. The child was all right at 3 months and then came back. What
Yes.
investigations you have at that time?
At 3 months of age, we have got an X-ray done when he has presented with complaints of.
Oh, they did a rectal biopsy in 10th. One second. Go back to the previous. Go back to the previous slide. 10th day, you had some rectal biopsy done.
Yes, sir.
Okay, good. It was suggestive Hirschsprungs. So perhaps that is the reason for which they must have given rectal washes responding and discharged.
Yes, sir.
Child is all right for 3 months and the child is presented 3 months back.
Yes.
Go ahead.
At 3 months of age, he has again presented with complaints of abdominal distension, foul-smelling stools, and fever for 1 day history and refusal of feeds. For which, at this point, we have repeated an X-ray that showed this was an plain X-ray AP view of an abdomen and chest and pelvis, showing dilated bowel loops more in the periphery than in the center.
So what do you think has happened now? This particular
Probably
presentation.
this could be Hirschsprung associated enterocolitis episode.
So what is the worry here? Apart from what the child presented with, what else can happen?
Sepsis and toxicity.
It can go into perforation also.
Yes.
Because of the dilatation of the bowel. If it persists, not only sepsis, which has happened here, you can have blood in the stool, but you can have perforation also. Okay. So how would you manage this?
We would manage by decompressing the rectum and later on giving antibiotics and rectal washes with antibiotics, with primarily resuscitating the child at the initial phase with IV fluids and antibiotics.
Yeah. And if you have an episode of enterocolitis, how much would you wait to do anything else, any other procedure? Would you wait or you would?
We would wait for the enterocolitis to settle down.
Okay. Okay, go ahead with the next investigation.
Once this enterocolitis episode of
What
the
was done
child,
after this?
we have done a rectal dye study.
No, okay, Chaitanya, go to the next slide. We are running a short of time. Show the rectal dye study, please.
Sir, rectal dye study which was done at 3 months of age.
Read this and tell me, is it conclusive? Okay, simple. Now we're going to go for T20, last hours, log over. Okay, we don't have much time. Now, do you think this is completely suggestive of Hirschsprung? Yes or no?
Yes, sir.
Where do you think is a transition zone? Please show it.
Transition zone, I feel it is at the splenic flexure, sir.
Show it, please. Point it on
Here.
the laptop. With the cursor. It's not
Can
very
you see?
convincing, no? Because it is proximal that they will tell.
So in this lateral X-ray, we can see that it
I
was
don't know what
narrow to
Dr. Prema feels. I feel that
No, that is narrow, whatever is being shown just now with that red marker. But somewhere in front, in front of that loop, somewhere in front of that, it is dilated. Some loop is there. In front of that, anteriorly.
here.
No, below. No, this.
proximal to the right side.
Yeah, I mean, it's not very clear because lot of dye has been put.
Left.
Yeah, but yeah, maybe it is splenic flexure. I agree with you. Although this
Exactly.
dilated, I don't know where it is. It could be splenic flexure. But your history is not in favor. Why? At least in the first 3 months, you
He was
said that the
decompressing well
child
with
is
the rectal
infected.
washer.
Yeah, so that doesn't happen often with a comparatively longer segment of, yeah, it is more for a short segment, but your dye study does look like that. I mean, it does appear to be, at least in the first, yeah, the last 2 or 3 pictures, it appears to
Perhaps
be.
this is the reason. Perhaps they chosen to do biopsy than going for a stoma straight away.
I mean, but this child with this contrast study, I think should have undergone a colostomy at splenic flexure earlier. Because he's gone into
I
enterocolitis.
understand. I don't say no. No. Child present with the enterocolitis, perhaps because the child had enterocolitis, the zone of transition is not clear. And when they went inside, they must have tried to do a biopsy, and perhaps they are not careful enough to suture it well, that the child had a perforation. Absolutely avoidable morbidity. But anyway, after that, they have done a colostomy in the right transverse colon because they're not too sure and must have done a multiple biopsies. What next? Chaitanya, we should be, Vikesh, we have about 5 minutes more to wind up.
Yeah, no problem, sir. Take your time.
1 minute, but 5 minutes at least.
I mean, for me, looking at the last picture, the transition zone is somewhere at the splenic flexure.
Okay, Chaitanya?
Yes, sir.
So
now
they
we
must
would-
have done a laparotomy at that time, and they must have seen some sort of transition zone, or maybe they were not clear about it because of the perforation, and they've done a right transverse colostomy and multiple biopsies. It's okay. Now, about the biopsy reports and what else would you like to do, Chaitanya?
Sir, we will assess. Now we'll go through the.
What are the biopsy reports?
Biopsy report was stating that all the segments from the rectum till the mid-transverse colon or aganglionic, and rest of the stoma side and the hepatic flexure are all ganglionated.
Okay.
Yeah. So I think that is
So definitely,
corresponding.
this adds to the diagnosis. That yes.
It is corresponding to the contrast enema.
What
Yeah.
Dr. Prema is saying about splenic flexion, about he said is corresponding. Agreed. Okay. Now, with all these things, what else would you like to do now? Next.
Now we'll see the nutritional status of the child to proceed for the definitive procedures.
So, because it's a long segment which will be removed.
Transition zone at
Sir, your voice was breaking.
Level of mid-transverse colon and a stoma at a proximal transverse colon. What would you like to do now? I don't know if it's my internet connection or somebody else's.
It's your internet. Would you please repeat the question? Would you please repeat the question?
So can I ask him, Vikesh?
Yes.
Yeah, please.
So what is the next surgical procedure you want to do, and how will it be slightly different from a routine main procedure? Because the stoma is at the transverse colon.
Yes.
Yeah.
I would like to go ahead with a tumble down retrorectal duodenal pull through procedure, ma'am.
Okay, please explain that. What exactly is it on? Is there any other way of doing that? So what exactly are you going to do?
Since the length is inadequate, we would ligate at the mid-colic artery at its origin, and the hepatic flexure and the cecum, and tumble down it down to the pelvis.
Any other way you can do this? This is correct what you have said. Any other way? I mean, because I do it the other way, so I'm asking you. So I often do a LADS procedure so that my small bowel comes to the right and my large bowel will come to the right, to the left. So it's similar. I'm disconnecting from the hepatic flexure attachments, but I turn it the other way and it comes very nicely, like without any kinking. I have no worries later on that something is going to fall over another and cause some volvulus or something. So I do the straightening procedure. Would you do anything else for these children? Because the appendix may not be, but in your procedure, the appendix and cecum are in their normal location?
Yes.
I suppose so, probably. Yeah. So because I turn it, I do LADS, I remove the appendix also. Okay. So what are the complications? Since here you have excised, I'm assuming you're excising the left colon, isn't it?
Yes.
What are the complications you expect in this child?
Immediate complications and late complications.
Yeah, good. Immediate and late. Yeah.
Immediate complications: leak, infections, synecdoche formation, constipation, and HIEC.
Okay. See, most commonly is wound infection, but yes, leak. You're worried about leak. So how do you reduce the chances of leak? You're doing a Duhamel, I think. So how do you reduce the leak? Like technically, what should you do? What are the reasons for a leak?
Tension-free, it should be mobilized without any tension.
Okay. And next.
What is crucial for anastomosis to survive?
Proper vascularity, sir.
Okay.
Okay.
So, and the suturing also, your suturing should be good. It should not be. So what happens often when you have a distal part which is aganglionic? How is it different from the normal bowel?
It is narrow in caliber.
Yes. So because there is a difference in caliber also, you may have issues when you do the anastomosis. You can have. So you have to be very careful. So will you be preparing the bowel or you don't believe in that?
We will prepare the bowel, man. We do a mechanical bowel preparation 1 day prior. We started in the day before in the afternoon. We give 20 ml per kg of this peg leg preparation over a period of 3 to 4 hours, along with IV supplementation, and whatever the child is taking, we will give it clear liquids until the previous night.
Okay. What else will you prepare? You prepared the proximal bowel. Will you prepare the distal bowel or not? Do you clean the distal bowel or not?
Yes, ma'am. We give enemas and we clear.
Yeah, I mean, it's important that you do a PR, remove whatever is there. And the distal bowel, since you have a divided stoma, you should clean that out. Just like
distal wash.
Yeah, distal wash is very important. Otherwise, while you're doing something, you have spillage, you more problems. So if you have a much longer length of colon which you have to remove, what are the surgical modifications you will do? Here you're just bringing it, you're tumbling down or whatever, and you're bringing it, doing a duhamel. But supposing you just have a little bit of ascending colon or something like that, then what are the modifications in the surgery in duhamel also? What do you do? So what I'm asking is, now you have a rectum. I mean, you have the whole left colon. Where do you cut how much do you excise of the left colon when you're doing this surgery? Because you have the whole colon now, which you have to excise, isn't it? Left side, you're going to remove. So what is a standard procedure for duhamel? I mean, how much, since it's no previous Hartmann's has been done. So normally, where would you close the rectum? Normally, supposing it's first time, you have a rectosigmoid and you are asked to do a Hartmann's procedure, where would you?
At the level of peritoneal reflection.
Okay, not exactly level. You want a little bit to be above the peritoneal reflection, because next time you have to join this rectum with your colon, which is going behind. So there should be at least 1 inch which you can close comfortably. So that much you should leave. But what I'm asking you now is, supposing you have a much longer length of aganglionic segment of the colon, would you do it in the same way, the same patient, instead of transverse colon? Your stoma is, say, somewhere near cecum, somewhere near ascending colon. Or let us say it is a total colonic aganglionosis. Would you do your Hartmann's or the rectal closure at the peritoneal reflection in the same place, or would you want it longer? What are the modifications of that duhamel procedure, which with a longer aganglionic segment? So, do you get my point?
In other
So
words, Chaitanya, what madam is asking is, what are the other modifications?
Kimura modification, sir.
No, what is Kimura? You should be
What is
clear
Kimura?
about.
Apart from Kimura, Kimura is a subsequent one. What is the original modification described? What is the original modification suggested?
There are two things. One is this question about modification specifically for the duhamel. So, do you open here in this child, you're excising, so your rectum proximal part is open, isn't it?
Yes.
So you're doing, I guess you putting a stapler and you will join the colon to the rectum. Do you do that?
Yes.
Yeah, rectum and colon you're joining. We are doing it routinely. There are some people who keep the rectum closed. What I'm saying is, if you have a longer length of colonic aganglionosis, you may want to leave a longer length of the rectum inside. That is, you may leave a little bit of sigmoid also, so that you have some more absorptive surface. You may have some constipation, but the diarrhea part is reduced. So it's a bit tricky, but you may keep a longer length, because here you have the entire bowel. You can do what you want. So if aganglionic segment is longer, so you may be excising most of the right colon. Then the left colon, you may leave a little more, but it will have its own complications. The child may have enterocolitis, may have constipation also, but sometimes that may be acceptable compared to having diarrhea, frequent stool, because of absence of colon. That's what I was trying to ask you. Okay.
Thank you very much, Dr. Prema. This is at that time that I would like to highlight to other people to please understand that it's not just about what is classically described in textbooks. What Dr. Prema has told about at least two important modifications which may not be widely publicized or textbooked, but it is necessary to know. One is about an alternative to tumble down is to do something like a malrotation. What she's suggesting is release the entire right colon, shift it to left, and then do it. It is fantastic. Second thing, like what she said, is to leave a longer segment of the rectal stump in cases of long segment Hirschsprungs, so that there is going to be more absorptive surface. This is where I think we have to understand that there are a lot of innovative modifications even from our own side, that we have to think. Am I okay, Dr. Prema?
Yeah.
Because I do this
Vikesh?
labs
Yes,
routinely.
right,
So,
sir.
yeah.
It's a very good point she had made, and it's basically we should develop lateral thinking in special circumstances. This is what she intended to mean. Sir, could
Exactly.
we,
So, Prema, I definitely learned two important things from you. Thank you very
Okay.
much. I think from my side the questions are through. If Dr. Prema, because I think it's around 9 o'clock.
Time is a constraint.
I
Yeah.
understand it's a big topic and it cannot be covered in 45-50 minutes. But anyways, we are going to continue this mock exam and it will again come up some other
But
time.
Vikesh,
Yeah.
yes, one thing I have to
I-
tell
I
that at least
to
both of us have
ask
been sort of complementary to each other, and you've
I
been
want to
really
ask one
supportive.
question.
Yeah.
Sorry.
That we asked
One-
commonly asked what I call a stock question. Here, tell me. Yes.
Yeah, ma'am, please.
Can I ask one more question?
Yeah, please.
Yeah,
Last
just
question.
one last question. What is Ziegler's myotomy, myectomy?
Posterior rectal wall myotomy.
No, Ziegler. I don't know if I'm pronouncing it correctly, but okay, you read it. So he'll read it. So it's over from
Yeah,
my
so you
side.
gave him homework, and I understand Chaitanya was very brave. He was just told in the morning to prepare the case. He's still in the second year. I really compliment you, Chaitanya, for taking it head on, and you presented it quite well today and faced all the questions very smartly and confidently. I compliment you. So
Yeah, I
you
also
still
feel
have
that
1 year, so this is going to be a good beginning of your preparation for the examination, I guess. Now we'll move on to the rapid fire round. I invite Professor Dr. Manish Pathak. Dr. Manish Pathak, are you there?
Yeah, hello. Good
Yeah,
evening.
I just
Thank you very much, Prema. It has been a wonderful coexistence. No, before
don't leave, huh? Just continue because this is again going to be some discussion here. So don't leave, Dr. Ramesh.
I might leave. I have to attend
Okay.
another meeting at 9 o'clock.
Yeah, okay, ma'am. Okay. You told me
Thank
that.
you.
Yeah. Thank you for joining, ma'am.
Thank you.
Okay.
it was been
Dr. Manish, you are
a
host.
lovely interactive. Thank you very much.
Dr. Manish, you are host now. You can share
Okay.
the slides. You stop sharing Chaitanya, please.
Okay.
Then stop sharing. Then stop sharing.
Yeah, Dr. Manish,
Okay.
now you can share your slides. And Chetan is
Okay.
going to preferably give the answer. Other people can chip in there in the chat box with the answers if here, I mean, parallelly you can do that. Yeah, please go ahead.
Okay. My screen is visible.
Yeah, it is visible.
Okay.
Just make
So,
it slideshow.
yeah.
Yeah, right.
So, after this excellent discussion on Hirschsprung's disease, what we will be doing is we will be recapitulating what already has been discussed, and there are few questions by which we will try to understand the Hirschsprung's disease. So, I will be asking the questions, and maybe you may just give the answer on, chat box, and then we will be discussing the best possible answer in that scenario. So, here we start. This is the question 1. So, absence of transition zone on contrast anemia examination in a case of Hirschsprung's disease may be due to all except option 1, Hirschsprung's associated enterocolitis, second, total colonic aganglionosis, third, using barium as contrast instead of water soluble contrast, and the fourth is overfilling of the colon with contrast. So maybe in 30 seconds, you may answer this.
Unmute yourself, Chaitanya. Unmute yourself. Yeah.
So, Dr. Chaitanya, yes.
Using barium as contrast instead of water soluble contrast.
Yeah, so we know that the transition zone, which we usually see in contrast anemia in cases of Hirschsprung's disease, it may not be seen in certain conditions. And these are if a recent episode of enterocolitis occurred, or the patient who is already on colostomy. In newborns also, sometimes it may be absent. Or when we are doing this study, we pass the feeding tube too much in so that we bypass the aganglionic segment, or if there is overfilling of the contrast so that the collapsed portion also gets distended. So these are the various reasons in which the transition zone may be absent. So yes, the correct answer is that using barium as contrast. So barium can also be used in older patients. It delineates the bowel well. So, but in a neonate, when we have other differential diagnosis also, we prefer to use water-soluble contrast. Okay, now let us move to the second question. Leveling colostomy in Hirschsprung's disease means colostomy few centimeter proximal to the grossly visible transition zone, colostomy in a frozen section proven distal most ganglionic bowel, right transverse colostomy in all suspected cases of rectosigmoid Hirschsprung's, or sigmoid colostomy following confirmation of ganglion cells by pathological examination of a formalin fixed tissue. Yes, Dr. Chaitanya. Dr. Chaitanya?
Sir.
Yeah, what do you think?
Colostomy in a frozen section proven distal most ganglionic bowel.
Yeah. So the leveling colostomy means that we decide at the time of when we are making the colostomy, we send a frozen section, and then we see which is the most distal portion, which is ganglionic, and we make the colostomy at that site. So basically, if we do not have the frozen section facility, sometimes we tend to make a colostomy based on the gross physical examination, but we should not label it as leveling colostomy. Leveling colostomy ideally means that it has to be proven by a frozen section examination. Okay.
On the following one.
No. This is the third question. Yes, Chaitanya.
Splenic flexure mobilization.
Okay. So what about the first option, decreased risk of colonic torsion?
That is an advantage.
Yes, so that is an advantage because you can know the orientation of the bowel when you are doing a laparoscopy. Okay.
Yes.
During transanal pull-through, the 360-degree rotation may occur and you may not be able to notice it. So this is a risk when you are doing a completely transanal pull-through, and you have to ensure the orientation all the time when you are doing it. So this is correct. Oh, okay. Now the second is less stretching of the anal canal during transanal dissection. So what about this option? Where this stretching will be less, completely transanal or laparoscopic assisted?
Laparoscopic assisted, it will be less.
Yes. So what you do is that you mobilize the bowel as distally as possible so that a limited amount of dissection is required to do when you are doing it transanally. So the excessive stretching of the internal sphincters will not occur. So this is another advantage of doing a laparoscopic assisted pull through. Then the third option is splenic flexion mobilization. So yes, this is also another advantage that, you can mobilize the retroperitoneal part of the colon also, splenic flexure also easily when you are doing it laparoscopically. While regarding better cosmesis and shorter operative time, complete transanal pull through, again, there is no scar at all. You are not giving any abdominal incision, and the operative time also, is shorter when you are doing a completely transanal pull through. So except the D, all other are advantages of doing it laparoscopically. Okay. So let us move to the another one. A 5-year-old child presents to the outpatient department. You will read it by yourself. Okay.
Number one, he had undergone transanal endorectal pull through 2 years back for rectosegment Hirschsprung. Anal manometry shows absence of rectoanal inhibitor effects with low resting pressure. What is the most probable cause for the fecal swelling in the patient? Retained aganglionic segment, persistent bone, damaged internal sphincters, rolled over pseudomuscular cuff. Pseudomuscular cuff.
Yes. What do you think? What is the answer?
Rolled over pseudomuscular cuffs.
Okay. So this question is basically based on the anal manometry. So what is the anal manometry finding is that there is absence of rectoanal inhibitory reflex. So this absence of rectoanal inhibitory reflex otherwise is characteristic of Hirschsprung's disease. We usually see it in the Hirschsprung's disease. Okay. Along with it, there is low resting pressure also. A low resting pressure in a patient who has already undergone surgery for Hirschsprung's disease, indicates that probably the sphincters have got damaged. So that is why the patient is soiling. There is low resting pressure, and the rectoanal inhibitory reflex will be absent because the sphincters are already damaged. So there is no point of relaxation or contraction. Okay. So the correct answer will be damaged internal sphincters. In the retained aganglionic segment, what will happen is the resting pressure will be high. Okay. So the best answer will be damaged internal sphincter.
Okay.
Okay. So now let us move to the another question.
Just the following is true for total colonic aganglion. Rectal biopsy usually shows hypertrophied nerves. Raised distal colonies containing lamina propria. Variable length of ileum may be involved. Absent to anal inhibitory. Reflex is pathognomic. Presence of transition in the problem. Variable length of ileum may be involved.
Okay. Yes. So what about the other options? One of the option is the rectal biopsy usually shows hypertrophied nerves and with raised acetylcholinesterase. So this is may not be seen in total colonic aganglionosis. This is one thing. This is a classic picture which we usually see in short segment Hirschsprung's disease. Regarding the another option, absent rectoanal inhibitory reflex is pathognomonic. So yes, this is there. This reflex is absent, but this is not pathognomonic because other conditions of Hirschsprung's disease will also lead to this absence of this RAIR. And then the presence of transition zone in the proximal colon will not be there in total colonic aganglionosis. So your answer is correct. It is a variable length of ileum that may be involved in cases of total colonic aganglionosis. Next question.
Total intestinal aganglionosis. Sir, Ziegler's myomectomy or myotomy?
Yeah, so this is the question which Dr. Prema was also asking, So this is the procedure which is done for near total intestinal ganglionosis. Near total intestinal ganglionosis is the condition in which only few centimeters of the jejunum is ganglionic, whole of the other bowel is aganglionic. So the portion of the distal part of the jejunum and part of the ileum, which is aganglionic. In that segment, we do myectomy so that some peristaltic movement can lead to passage of the stool contents through that myectomy segment also. And then we make a stoma little bit distal in the aganglionic part only. So this is what procedure has been described for near total intestinal aganglionosis. And other procedures are used for total intestinal aganglionosis. Okay. Next.
Which of the following is not true about the internal sphincter achalasia? Absent recto anal resolves spontaneously by the age of 5 in most of the patients. Intrasphincter bottle injections curative normal ganglion cells and biopsy. It is So resolves spontaneously by the age of 5 years in most of the patients.
No, this is actually true. So internal sphincter achalasia does resolve spontaneously by the age of 5 years in most of the patients. So the option C, where we say that the intrasphincteric botulinum injection is curative. So it is not curative. It causes temporary relief, and you may have to give the injection again after 3 months to 6 months, depending upon the recurrence of the symptoms. So this question was a bit tricky, but here it is actually not curative. That is why the best answer is B only. Okay, which of the best? The answer is C. Okay. Next. All the following are risk factors for developing HAEC except Hirschsprung's associated enterocolitis, except long segment disease, trisomy 21, post-operative incontinence, younger children. Yes, Chetan.
Long segment disease.
So again, long segment Hirschsprung's disease is a risk factor. When the patients who are having long segment, they have a higher risk of developing HAEC. So, and trisomy 21 also is a risk factor. Younger children also, in older children, the HAEC is relatively less common. So, but the patients who, have post-operative incontinence, suggesting that probably the sphincters have been damaged. Surprisingly, those patients, they have less HAEC, maybe because less stasis is there in those patients. So the answer will be C. Okay, all others are risk factors. Yes, question 9.
Short segment Hirschsprung disease.
Yeah. So this is a classic presentation of short segment Hirschsprung disease. Rather, when we do this acetylcholinesterase staining, so increased acetylcholinesterase content is seen in short segment Hirschsprung disease, while it may not be seen in ultra short segment and total colonic aganglionosis, and not in internal sphincter achalasia also. So your answer is correct. It is short segment.
Dr. Manish, can I ask you a question?
Yeah.
Yeah. Why is it so that in total colonic aganglionosis, this finding is not seen on biopsy? Is there any particular reason for that?
So this acetylcholinesterase content, which we usually see that they are raised, this is a characteristic finding. The Prempuri actually had studied in many of these patients, and what he found was that. So surprisingly, what he found was that in ultra short segment Hirschsprung's disease, these HAEC, this staining, acetylcholinesterase staining was not showing the raised contents, and similarly in total colonic aganglionosis also this was not seen. So the next question about Desmosis coli. So Desmosis coli is characterized by constipation, rectal biopsy showing lack of connective tissue net in circular and longitudinal muscles, and abnormal enteric nervous system. The second is constipation, rectal biopsy showing lack of connective tissue net, but normal enteric nervous system. The third is desmoid tumor of the colon. And the fourth is segmental dilatation of the colon with watery diarrhea. So, yeah, Dr. Chaitanya.
Option A, sir.
Yes. So, the constipation, yes, desmosis coli is actually one of the differentials of Hirschsprung's disease. It is a rare condition. These patients do present with the similar constipation as we see in Hirschsprung's disease. And basically on histopathological examination, there is a focal or complete lack of connective tissue net, but the enteric nervous system abnormality is not there. So the answer will be B, that there will be constipation. The rectal biopsy will show the absence of connective tissue net, and because of that, this motility is there and these patients have constipation, but the enteric nervous system is normal. Okay. So these are the few questions which we had for this Hirschsprung's disease. Yes, over to you, Dr.
you.
Vijay.
Can you show your face once for everyone so that everyone identifies you, Manish?
Yes.
So thank you very much for chipping in today and making such a good quiz. It was really informative to all of us. Even I was benefited with that. Thank you. Thank you, Dr. Manish.
Okay, thank you.
Thank you, Manish, and thank you, Vikesh.
Yeah,
I
please.
need to congratulate all of you because it's been fantastic. And I think it's a great initiative by IAPS to reach out to younger people, to make it more useful, to make it more participative, and to make it more democratic. Vikesh, you're doing a brilliant job. Heartiest congratulations and wishes. And thank you for involving older people like us too. Thank you.
You are still young, sir. Thank you so much, sir, for joining and generating a very good discussion along with Dr. Menon. Chetan, again, I thank you and wish you all the best.
Thank you.
Thank you. See you again. Bye-bye. Good night.
Okay, thank you.